Dr. Tulin is the Gattuso Chair in Breast Surgical Oncology at the University Health Network, Princess Margaret Cancer Center. Dr. Sill's research spans various topics, including development of virtual care platform for breast cancer patients and innovative teaching strategies for learning surgical skills. Our presentation tonight is entitled Surgical Options When a Mastectomy is Suggested. Dr. Tulin Sill, Surgical Options When a Mastectomy is Suggested.
Well, thank you, everyone. I'd like to thank Dr. Brown and the organizing committee for the invitation to talk tonight. So over the next several minutes, I'm going to talk about mastectomies in general and indications for them, approaches to them, and how we think about different options for mastectomy when a patient needs to have one or chooses to have one. So I've sort of gone over those three objectives there. So you've heard a little bit about the evolution of breast reconstruction, and certainly from an oncologic perspective, breast cancer surgery has significantly evolved over the last century. William Halsted really pioneered a very oncologically successful but aggressive approach to mastectomy, where the breast tissue was removed along with the underlying muscle and all of the lymph nodes in the underarm. And this left patients with good disease control sometimes, but significant morbidity afterwards. And we know that with early detection now we're finding cancers much smaller and earlier stage. So a lot of our patients are actually good candidates for breast conservation, lumpectomy. But there are still situations where mastectomy is the better option. And we can think about that in terms of two groups of patients. First, for those patients who have a breast cancer, so they need mastectomy for treatment, and also for those patients who are at high lifetime risk for developing breast cancer, and so we can use bilateral mastectomies to reduce that risk of breast cancer as much as possible. So as I said, in terms of contemporary surgical approaches, most of our patients do undergo breast conservation, so 65% will have lumpectomy, but over a third will need a mastectomy for breast cancer treatment. And who should really have a mastectomy? Well, these are some of the more concrete reasons. So when we talk about multicentric disease, we mean disease in many areas of the breast, more than one quadrant, more than 5 centimeters apart. It's very challenging to get clear margins and remove disease by doing multiple lumpectomies in one breast. And so generally those patients should have a mastectomy for ideal treatment. If you've had previous radiation or you can't undergo radiation for some reason, that would be a reason to do mastectomy, because we know that lumpectomy is only as effective as mastectomy if you include adjuvant radiation in general. And so if there's a reason you can't have radiation or don't want to, mastectomy is better. Pregnancy-associated breast cancer, if they're early on, again, they can't undergo radiotherapy in a timely way, so mastectomy may be better. And if you've had a lumpectomy, but the edges are not clear, so that's what we call positive margins, if that happens despite multiple attempts at trying to get negative margins, you'd be best served with a mastectomy. Some of the other kind of more relative indications, a small breast size, really dependent on how big the area of disease is. So if you have a small breast and a larger tumor, it's not going to be cosmetically a good idea to have a large lumpectomy. Collagen vascular disease means that you can't have adjuvant radiation, so that's one of the other, as I said, indications. How about choosing to have a mastectomy in the situation where both are good options for you? There are some tools out there like decision aids where patients can look at the pros and cons of each of these approaches and then decide for them what makes most sense. We do know, as I said, that the survival is the same. And recurrence can happen in the area in both situations. So having a mastectomy doesn't mean that there's no chance of recurrence. It just means it's extremely low. This is asked a lot. What about the other breast? If a patient has a mastectomy on one side, what should they do for the other breast? In general, the risk of a breast cancer on the other side is really quite low for patients who don't have a genetic mutation. And so that's really a very thorough discussion that you should have with your oncology team about what your risk is for the other breast and if it makes sense to have mastectomy either from a cancer control point of view or from a reconstructive point of view. Okay, types of mastectomy. Well, a traditional total mastectomy means we remove the nipple and the areola in the center. Just use that pointer there. Yep. So most of the breast skin is removed along with the nipple and areola. When we look at immediate reconstruction, we do spare the skin envelope, and so that's where you're talking about the skin sparing or the nipple sparing mastectomy options. Okay, about reconstruction and the timing of reconstruction. So this is always a question we discuss, particularly in the treatment setting. For some patients, immediate reconstruction may not be the best idea, especially if their cancer is much more advanced. If there's skin involvement, we do have to remove more of the skin, and so a delayed reconstruction may be better. But thankfully for most patients, this is a good option to discuss. There's pros and cons as we talked about. And on the plus side, you may have fewer surgeries overall. From a cosmetic point of view, sparing the skin and the nipple certainly gives a more natural appearance. And for some women, it's really important to have some sort of immediate reconstruction at the time of losing the breast. It is a longer surgery, there's longer recovery, there may be more complications when you add both things together. And sometimes it can be a little bit of a logistics coordination that you need to do with the other team. And radiation after mastectomy is always a question mark. So some patients will still need to have radiation even with a mastectomy. And in those patients, we really need to factor that in and use that to guide their reconstruction as well. Okay, delayed reconstruction separates the two procedures. So in that case, a patient would have a total mastectomy and then reconstruct at a later date. And as you can see, some pros and cons there, allowing you to just focus on the cancer treatment when you do it as a delayed and not kind of have the full operation with reconstruction is more straightforward for some patients. But as I said, depending on the other treatments that you have, sometimes the delayed reconstruction may be a little bit different in terms of the options available. You'll hear all about the different types of breast reconstruction surgery coming up, so I'm not going to get into that, but in general terms, either using an implant or your own tissue. And then in terms of not having any reconstruction, that's certainly something that we see in more recently. I think patients are exploring what about a flat aesthetic closure and remaining flat. And really, I think this is a personal choice. It's specific for every patient and their own situation. Really, every total mastectomy should aim to have an aesthetic flat closure. So we don't want to leave excess skin if we can. We want the contour to be as flat as possible after removing the breast. Because that's really going to be beneficial for patients in terms of using a prosthesis and a post-mastectomy bra as well. So there are sort of different techniques to achieve a more flat closure, but generally this is the goal if you're not going to have a reconstruction at the same time. So these are some of the questions to ask your oncologic surgeon when you're talking to them about total mastectomy without reconstruction. What would the contour look like? Everybody's chest is different, everybody's body is different. So no two outcomes will be the same. Where will the scars be, and how can we make them lay as flat as possible? So I hope that gives you a good sort of summary about when we do mastectomy, why we do it, the surgical approaches, and the really integrated discussion with our healthcare team. This is a great guide, actually, so if these slides are available later, I would encourage everybody to check this out, and I'm always happy to answer questions. Thank you.